Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline is where we like to focus on ways to live a healthier, happier, and pain-free life. And we'll be taking your calls and answering those questions live in the studio today. And before we get to that, I want to introduce today's guest. You probably know who they are, Dr. Wyche Coleman III and Dr. Christopher Shelby with WK Eye Institute. Thanks, guys, for being here.
Yeah, thanks for having us.
Yeah, it's good to be here.
Absolutely. So you guys are the eye experts, but we also like to talk about a lot of different things. But typically, your focus is cataracts, right?
Yeah, mainly cataract surgery.
Yeah.
So, we're just talking about that before the break that, we've had a complete remodel of our operating rooms. We're pretty excited about that. We've been back in them for about a week now. We'd moved out to the main OR for 4 months, and, we were anxiously awaiting getting back. And now, in the past, one of the main differences for the patient flow experience is that prior to this remodel, we only had 3 rooms to work out of. Now we have 4 rooms to work out of. Occasionally, there's like an emergency case, like maybe a retina specialist needs to come in or one of the other ophthalmologists in town and they need to do a case emergently. Well, before we'd have to let them use our 3rd room and we would just go down to 2, slowed things down a little bit, made the wait times be slightly longer for people who are waiting for us to do surgery. Well, now we've got 4 rooms, so they could use the 4th and we continue to be able to operate with 3. So I think it's going to make the total time from when you walk in the door to when you walk out a little bit less, which is great. And it's a facility that's specifically designed now to do nothing but cataract surgery, basically. That we do a few other different types of eye surgeries there, but 95% of it is cataract surgery. And the workflow, the layout of the place is specifically designed to be very efficient for that.
Gotcha. And so that's typically where you operate, but you still have your typical clinic locations as well, correct?
Right.
So, but it's different. That's where you typically would operate.
We like to make it as complicated as possible. Yeah. So, we always get people showing up at the clinic for surgery. So, yeah, if you're coming to see us in the clinic, it's at our respective locations at North, South, Piermont, and then all of our surgery is done at a single location. What used to be the Steen Hall Eye Institute, the WK Eye Surgery Center, which is the 5-story building off of Greenwood Road. You can see it from the interstate from I-20.
Yeah. But yeah, it makes sense. So
you're too young to remember when it was the Steen Hall Institute.
Yeah, I must say that.
When I'm not from here, so.
Most of our cataract patients remember it though.
Okay, very cool.
We say Steen Hall, they know what it means.
We say Steen Hall, they know exactly what we're talking about.
Okay, cool. And so cataract surgery is one of the most, would you say, common procedures?
It is actually the most common procedure performed on Earth. And the good news is everybody gets cataracts as you get older. And so that's just a natural change of your God-given lens. And that's one of the reasons we get in reading glasses. We begin to wear glasses as we get older. We get glare at nighttime, trouble reading small print, things like that. And so in the United States, luckily, when those symptoms become to the point where they're affecting your quality of life, then we can take them out. And the surgery is nice, very efficient, takes about 10 minutes at most, it's painless. The results are almost immediate. Most patients notice an improvement in brightness and colors that day, and by the next day they're seeing very well. And usually within that week or a week later we do the other ones to match them up, and it's amazing the results that we get from cataract surgery. It is incredibly safe, and that's one of the reasons we did the remodel, is to make the experience much more pleasant for patients in general. Okay,
and one of you mentioned you do about 100 surgeries a week with cataracts. Is that between the both of you?
It's between the both of us, yeah.
Wow, that's incredible.
Dr. Shelby's the big dog, most of them. I'd say, what do you do, about
70 to 80.
70, something like that.
So
I do about 30, so we may do over 100 every week.
Yeah, we do.
Okay.
Yeah.
So you said 10 minutes is the procedure, but from start to finish, what does the time look like for that?
It's about an hour and a half.
Okay.
So patients come in and so the thing about us having different clinics, we try to make it very convenient for patients to be seen routinely. And of course, when you have cataract surgery, theoretically you're only going to have it twice. One for your right eye, one for your left eye, and so that's why we like to have the central location. And so when patients get there, there's the obligatory paperwork. It's like, here you are, got to fill out, Ms. Smith, fill out the paperwork. They have to do intake, start an IV, and get you dilated. So from the moment somebody comes in through the double doors to the time they're wheeled out to their car is about an hour and a half.
Yeah.
And so even though the procedure, once we get a patient back in the operating room, from the moment we sit down to the moment they're being wheeled out is about 10 minutes. It's not too long at all.
That's awesome. And that's probably why you're able to do so many during the week.
And we have great staff. I mean,
Yeah.
The staff is great.
They make it possible for us.
Okay, cool. So what are some things to look out for? You know, like most everyone, when you get to a certain age, you're going to experience this. But what are those classic symptoms when someone should really address it?
We know blurry vision is never normal. You typically shouldn't think about your vision. It should just work. And if it's not working, especially if you get to the point where you don't see clearly, if you've never worn glasses and you get to a point where you're not seeing well, could just be that you need a glasses prescription. Could be other things. If you're in glasses, and especially if they continue to change in your 60s or 70s, where the glasses prescriptions are changing rapidly, or you feel like you get glasses and they're never good. So this is a common thing with cataract surgery. Patients, as they come in and they'll have 3 or 4 pairs of glasses. They'll say, I keep getting these glasses prescriptions, they're not making them right, I can't get them right. You know, you look, there's a cataract. That's the underlying problem. That's a real common thing. Or in general saying, I don't see as well as I need to drive at night with the best glasses or contact prescription, and there's nothing else going on. That's probably time for cataract surgery.
Mm-hmm. Okay, and you said most people see a big difference within, a week or maybe even the next day of having that surgery. So it's pretty life-changing, would you say, in some ways? Yeah?
Yeah, we have the best job ever, I'm telling you, because the cataract development is like a glacier moving. It's very slow and subtle over time, and we'll talk to patients preoperatively, and they're like, they realize they don't see as well as they used to, and so they don't realize how good they're going to see because the process over 30 to 40 years of cataract development has been slow and subtle. The results from surgery are instantaneous.
Yeah, that's awesome.
So, one of the things that that I wanted to touch on today is, we hear a lot in we talk about lenses. We go and take the cloudy cataract out and then we put a lens implant in its place. That's to replace the focusing power of the eye that was in the natural lens. And we'll take the caller right quick, but I wanted to just run through the lens options because I know people watching they're interested in that. They're interested in that when they come in the clinic. We run this tape in the clinic. So thought it would be good to run through what all the lens options are and sort of just a little brief overview of what the purpose of the different ones are.
Sure, yeah, we'll get to that. And we have a caller. Verna, thanks for joining us. And what's your question?
Yeah, I was checking. I was trying to see can I.
Oh, I think we just
Might have
lost
lost
you. Yeah. What was that question? Did we lose her?
Well, my eyes.
I think we're only getting like every third word.
Yeah.
Can you hear me?
I can hear you now. Let's try it again.
He blinking like a lot. Like.
Yeah, it sounds like there's a bad connection.
Yeah, I think we're only getting every third word. Maybe try calling back and see if we can get it clear. And
maybe move to a different area of the house or stand outside or something.
We're only getting like every third word. In the meantime, we may dive into a few of the lens options.
Yeah.
So when somebody comes in for a cataract eval, we're generally trying to look at a way to make them as glasses independent as possible. So we're going to take the cataract out, we're going to put a lens implant in. 50 years ago, you'd take the cataract out, you would replace the focusing power with nothing. You'd have to wear thick Coke bottle glasses. Hadn't done that in a long time. A lot of the technology surrounding cataract surgery has led to the ability to get you glasses independent afterwards, where even if you've been wearing them your whole life, you don't need them after cataract surgery. So when somebody comes in, we're trying to look and say, based on all of their objective measurements, what is the best option to leave them with glasses independence? So our go-to multifocal lens at the present time is the Alcon Panoptics. That's the one we use the most. It's the best one we've ever had. There's a few new ones on the horizon that we'll be looking at soon. But it's an excellent lens. 99% of people don't wear glasses for any task with that lens. So if someone is a candidate, if they have a normal retina, if they have relatively normal cornea, no real bad dry eye issues or anything like that, that would be the go-to. Now, someone who's had previous refractive surgery, RK, LASIK, something like that, we'd probably go towards a light adjustable lens. And that's a lens that we can put in the eye. And instead of having to pick the exact correct power to put someone in perfect focus, we can go adjust the power afterwards. And that's good because it's a little bit harder to do precise measurements on people who've had their corneas reshaped with LASIK or RK surgery in the past. That's an option. toric lenses for people who have a lot of astigmatism. That's an astigmatism correcting lens that goes in the eye, and typically we'd be going for a distance target, or perhaps if someone's been in what's called monovision, one eye at distance and one eye at near. A lot of people do that with contacts. If people have done that in contacts, we usually just replicate that with the lens that we put in the eye. Now, there's some people who have very abnormal eyes, and we have some lenses now that are very specific to that. There's what's called a small aperture lens, and if you've been to the doctor's office, the eye doctor's office, you usually notice when they're trying to figure out if glasses will help you, they do what's called a pinhole test, where you look through some little tiny holes. And if you can read the eye chart way better looking through the tiny holes, that probably means that you need a pair of glasses. Well, some people have a real abnormal shape to their cornea because of diseases or previous surgery or trauma and scars. And there's a lens you can put in your eye that has that same effect now. That's called the aphthera. That's a small aperture lens. So some of the people we couldn't do a whole lot for in the past, because they have a very abnormal eye, we can do something for with the aphthera lens. So the range of options that we have to help people who previously we couldn't do a whole lot to make their vision perfect or give them a high level of glasses independence, we got a lot of options. It's very rare for someone to fall through the cracks where we can't do anything to give them glasses independence. That does occur, but for people who desire to become free from glasses, usually cataract surgery can achieve that through one means or another. So the main part of the workup is to take a lot of objective measurements to try to figure out what someone's a candidate for, to make the correct choice on lens and surgical process to leave them independent of glasses afterwards. That's
Gotcha.
sort of the point of what we do.
Okay, and so is this something that you would do simultaneously when you are doing cataract surgery as well?
Correct.
Okay.
Yep. So it's like we're choosing how we're going to do the cataract surgery and what implant we're going to put in the eye to achieve the goal of minimum glasses use.
Gotcha. Cool. All right. Well, Kay, thanks for joining us. And what is your question? Tay, I'm sorry.
Yeah, my question is, I really can't see too good. How can I get that fixed?
Come see us.
Yeah, it depends on what's going on. Yeah, you just give us a call and come let us take a look, and then we can figure out, first of all, why you can't see well, and then based on that, then we can come up with some solutions to get you seeing better.
It's like real blurry vision. I got real blurry vision.
Yeah, well, that's not uncommon to have blurred vision. We just need to figure out why. Do you generally wear glasses?
No, sir. It happened after I woke up one day like this.
Yeah.
Well, that is worrisome.
Yeah, that's a little more worrisome. Matter of fact, probably not a bad idea you can call one of our offices and get seen. Actually, today is not a bad idea. I mean, no later than Monday. And you can call 212-3937. If you're close to North, you can call 212-2020. And if you're out by South, you can call 212. What the?
Yeah, I think that was a robot. Yeah, if someone's at Piermont, you should be seen today. Yeah. Call them and tell them we talked on the TV. Call 212-3937.
Yeah.
Tell them we talked on the TV, and they'll get you in today.
Yeah,
for sure.
We've got somebody there right now that can see you.
Yeah. And thanks for your question. If you're just joining us, give us a call, 318-219-4569, to talk directly with our doctors. We're talking all about eye health, cataracts, lenses, anything under the sun when it comes to eyes. And so what would what would your guess be? I'm sure it could be a number of things, maybe sudden onset of blurry vision. What does that typically indicate?
That is a long list.
Yeah. We only have like 20 more minutes. So.
Right.
I feel like I'm taking boards here.
Yeah.
It's sort of answering a question in a vacuum. The good thing about ophthalmology, the bad thing is like telehealth. There's some role for that in the world that's trying to be expanded through this broadband access program for the state, which I think is a great thing. I think you can do like psych and some general medical stuff over telehealth. You can probably do a lot, but we learned during COVID you can do almost nothing with ophthalmology over telehealth. Now, if somebody has a red eye, they can send you a picture of it, but as far as determining what is causing vision loss, it is pretty much impossible. So we are dependent on exam findings. You know, a lot of aspects of medicine, you're real dependent on people telling you their story. That is important. I want to, you know, degrade the importance of a history, but even if someone says nothing, if we can do an exam, we can usually figure it out. And if we can't do an exam, it's real tough.
Yeah, well,
it could be a lot
honestly,
of things.
that just points back to the importance of getting seen quickly.
Yep.
So, okay. All right, well, Chloe, thanks for joining us, and what's your question?
Thank you very much for taking my call.
Yeah, thanks for calling.
Absolutely.
I just need to ask the doctors. I've got partial coverage on my right eye, and it is cataract. If I have that removed, would it be permanently removed, or do I need to wait
Yes.
until it covers more?
No, so that's a common question. In the old days, they would use the terminology a ripe cataract, and that was back in the days when cataract surgery was pretty scary, and you wanted to wait until the cataract got really bad to make sure that you had a high probability of making the vision better. That is not true in modern times. As soon as you're noticing a decreased vision from the cataract surgery, the odds are overwhelming that you're going to see much better afterwards. So, and once it's removed, it's gone forever. So, you know, the cataract is a clouding of your natural lens that occurs over time. That sits behind your pupil. You know, the pupil or the iris, the colored part of the eye, the lens is just behind that. So we go in and we take that lens out completely. The capsule that surrounds it, which is the structure that holds your natural lens in place, we put a clear plastic lens inside that capsule. It scars it down into a permanent position. So once the cataract is gone, it can never come back. Now, you'll commonly hear of a phenomenon called a secondary cataract, and that's sort of a misnomer. It's not truly a cataract, but it mimics the symptoms of a cataract, and that's basically that capsule that surrounded your natural lens where the cataract formed. We open a hole in the anterior or front portion of that capsule. We take the cataract out through it, and we put the new lens implant inside that capsule. The posterior or back portion of that capsule remains intact, and it wrinkles up some. And that's what we have to shoot a hole in with a laser. That's what we call a secondary cataract, just because it's easier to say. And it mimics the symptoms of a cataract. But truly, once your cataract surgery is done, you will never have a cataract again. So if it's bothering you and you know you're not seeing as well as you need to, that's a good time to get cataract surgery done.
Very encouraging. It's like when I look away from me, like driving or something, it's like a fog, but it's not, bad for my vision. But I think when I really do really close-up things, I have a problem with it.
Right.
Like reading a measuring tape or making a mark on some wood or something like that.
Well, it sounds like you're doing some good carpentry at the house. So, but getting the mark right is important. So, the other thing that happens with cataracts is most of the time they progress pretty slowly, and so even though you don't think there's a big deficit in your vision, when we remove the cataract, it may be a dramatic difference where it was actually worse than you thought it was, and that's a pretty common experience where people say, it's decreasing my vision a little bit, but not too bad. But then they have cataract surgery and they're like, oh my gosh, I was seeing a lot worse than I thought.
Uh-huh.
So give us a call. We'll be glad to do it.
Well, I appreciate that. Well, I'm 84 years old, and I'm still going strong.
Good. Keep it that way.
And I don't want this to hold me back.
Yes, absolutely.
Thank you very much for your time.
There's no age limit on cataract surgery. So, and the average age is 69. So you've made it a little ways past that already. So I could, without even looking at your eyes, I would go ahead and make a side bet that it would make a dramatic difference in your vision.
All right. Thank you very much.
You're welcome. Thanks for the call.
Thanks for the call.
Absolutely. And if you're just joining us, 318-219-4569 is the number to call. So you can ask a question, and we have another question from a viewer.
Let us say right quick before we take Donna that if you call, if the last caller is still listening, if you say you talked on TV, we always give appointment priority to our KTBS callers. Yep. They'll get you in immediately.
All right, yes. And Donna, thanks for joining us, and what is your question?
My question is like, I've already had 2 cataract surgeries, and I've already had 2 detached retina surgeries. And now I still have all this scar tissue, but I'm considered legally blind, and I have something that is hereditary to men, not women, but it's like degenerative myopia, and it has a bunch of other things wrong with it, but I can't remember them all. Anyway, I have this scar tissue that just comes in now, and it takes the tops of everybody's heads off. When I look at people, it's like the top of their head just disappears on me. Is there any way to remove some of that scar tissue?
You know, when you've had a retinal detachment like that, and when you've got that pathologic myopia, it's because your eye's too long, you know, and so your eye's really long, you're really nearsighted, and it causes some thinning to the retina, which of course that leads to retinal detachments because the peripheral retina gets little holes and tears in it. You know, the problem is the retina is like the film of a camera, and so the issue that you're having is that area of the retina that when you look at somebody where the top of their head is, or just that area in general, you're not seeing because of the scar tissue, and so the retina has been replaced with some of the scarring. And those are those situations where there's really not a whole lot we can do about that. The retina surgeons do a great job to try to prevent that from happening and getting the retina laid back down. But there's nothing that we can do as far as lens-based surgery or corneal surgery that is going to improve that. And I'm sorry to say that, you know, of course, that's one of the tough parts of our job is when there's situations that we can't do a whole lot about. Now, we're glasses half full type of guys, and the fact that you can still see with both of those eyes after going through what you've been through is somewhat of a miracle, you know, and even though your vision may not be near as good as it used to be, you know, having some vision is better than having none.
I agree.
But yeah, I wish we had the magic bullet for it. But
I wish you did too.
You know, but the goal would be to preserve the vision that you have. So.
Yes. All right. Well, I take that Persevision. That's supposed to help it, huh?
Yes, ma'am. That's good, especially if you're over the age of 55, and that helps prevent certain types, or helps slow the progression of certain types of macular degeneration. And of course, with pathologic myopia, you're at a slightly higher risk of that anyway. And so, taking the Preservision is a good idea. Yes, ma'am.
All righty. Appreciate you. Y'all have a blessed day.
All right.
Thank you.
Too.
Thanks, Donna, for joining us. And if you are just joining us, give us a call, 318-219-4569. We love your questions.
Yeah, it's always good
we
questions.
love questions.
Yeah.
I will say, you know, people with a retinal issue, you know, it would be worthwhile some things cannot be fixed. It is worthwhile to maximize, you know, the quality of the glasses prescription. You know, sometimes you can do some things like that will give someone an improvement. And I think that sometimes people get sort of left behind where they say, well, you got this major retinal problem, and nobody even tries to give them the best glasses prescription they can give them, because it's sort of difficult when someone doesn't see well to even give them an accurate glasses prescription. But if you take time to do it, that can give them a significant visual improvement. Even though the vision's not totally normal, it doesn't make it perfect, it can make someone a lot more functional. So I would encourage anybody with a situation like that to, you know, try to get the best glasses prescription you can get, because it may make a difference.
And that actually leads into something else I want to talk about. You know, somebody who's got a retinal detachment, like Donna had bilateral retinal detachments, but some patients will have a retinal detachment in one eye, and once that gets fixed, they see pretty well, but the problem is they're a lot more nearsighted in that eye than the other one. And so there's what we call anisometropia, where, like, let's say one eye sees really well at a distance, the other one's really nearsighted. So even glasses in that situation can throw them off because of the image disparity. Those patients can actually have LASIK or PRK even after the retinal detachment to try to balance the eyes, which we've done on a number of patients. And even though we know, hey, they're not going to have that crystal clear 20/20, we can get the eyes matched up to where it's a lot more comfortable just walking around, or they can get a pair of glasses to balance things where the prescription's not so different. And so that's another option also, piggybacking on what Dr. Coleman was saying.
Yeah, and all of that, would that help preserve your vision as well with all these things that you're talking about? Too?
Maybe not preserve long term,
Okay.
but if you have some degenerative process, it may continue, but optimize what you have.
Yeah.
Enhancing
Maximize
it.
potential.
Yeah.
Gotcha. Okay. Ernie, thanks for joining us. And what is your question?
Dr. Shelby, I was wondering what causes build up, the fluid build up, and do you have to get it drawn off more than one time?
Is that, Ernie, are you talking about fluid in the retina or fluid on the cornea, on the front part of the eye?
The front part of the eye.
So,
Well, either one.
well, okay, so fluid buildup in the retina itself is caused by leaking of the blood vessels back there. And of course, that can happen because of inflammation, like after cataract surgery. And that's usually self-limiting. That usually goes away on its own, or can be treated with drops. Sometimes the retina specialist will do injections to get that fluid buildup to go down. And of course, what we really get concerned about would be more like macular degeneration, if that were to be from bleeding or leakage. The cornea, the front part of the eye, there's a layer of cells on the inside part called the endothelium. They act like a pump, and they keep the cornea clear of fluid. And with the endothelium, you only get one set. So if you lose an endothelial cell, you don't get a new one. So the other ones have to try to take its place. And that is a common situation where patients lose enough of the endothelium that can't keep the cornea as clear as it needs to be. And so that's why we'll put patients on drops like Muro 128, which is salty, helps to draw the excess fluid out. And that is a consequence of birthdays. As we get older, we lose some of those. And then we have cataract surgery, we lose some more. And then there's certain disease processes like Fuchs dystrophy that causes a loss of those cells. Once that gets to a certain point, and there's constant swelling or fluid accumulation in the cornea, that layer can actually be replaced. Matter of fact, Dr. Coleman's sister, the other Dr. Coleman, who's a lot more attractive than he is, by the way.
The real Dr. Coleman.
The real
right?
Dr. Coleman, yeah. She actually is she's a specialist in the cornea to where she'll be doing those procedures to where we can replace that endothelium. And nowadays, it's not like having a full thickness corneal transplant. It's outpatient. The procedure is very much like cataract surgery. The healing is very good, and the results are amazing. So I hope that answered the questions that you were asking as far as fluid buildup.
Is it painful?
Is it painful?
Is it painful?
No, it's very similar. Like I said, the cataract surgery, well, two things. Number one, injections in the eye, if we're talking about that part, believe it or not, do not hurt. And, needle and eyeball should generally never go in the same sentence, but everybody who's gotten it, it's the thought of it is much worse than the process itself. The DSEC procedure, the replacement of that endothelium, is no more painful than cataract surgery, which is not painful at all.
Interesting.
Okay, thank you very much. Dr. Bird years ago did my cataract surgery. Did you know him?
Oh, love
Dr.
we
Bird.
all know Dr. Bird, and we all love Dr. Bird. Yeah, so that was a while back because he stopped doing cataract surgery quite a while ago and focused on plastics. But yeah, I mean,
All right. Well, thank you very much.
you're very welcome,
thanks for
and
the
we
call.
can take a look at you anytime, Ernie, and get you set up with the real Dr. Coleman if that's the issue. So just
Right.
let
And
us-
that's a very attractive lady that's on TV today, too.
yeah, yeah. So
It's very nice. Well, thank you, Ernie. And we have just about a minute left. And tell us where we can find you, phone number, and where your clinics are located.
I'm at Walsite South, 212-5901, and our website's thecataractsurgeons.com. And I was maybe going to solicit the audience for the next time we're on. Maybe we could get some compliments. I don't know. I know you deserve them more. I'm just feeling left out now.
As long as you do a good job in the operating room,
Okay,
right?
fair
There we go.
Can't win 'em all.
that's right. That's all that matters.
Okay, where
Yeah.
are you located
And then
at?
I'm mainly at Piermont and Wilsonite North. It's 212-3937. And we have a location that's convenient for anybody. That's why we're at North Piermont and at South. So
All right.
give us
yes.
a call.
Maybe if I dress better. I'm going to try.
You got to wear
that.
the orange undershirt.
Maybe if you wore some fun socks.
Yeah,
like
that's
Dr.
right, the
Shelby.
eyeball
Fun
socks.
socks, yes.
All right. Well, thanks for joining us. This will be on ktbs.com/podcast.